Hi, everybody. I'm kind of short, so I hope this comes down. Maybe not. Anyway, I'll stand on my tippy toes so you guys can see me.
I can pull that down
Thank you.
and then this does work.
This works.
There's a pointer and then it advances your slides after the first one.
Perfect.
You have to do your first one.
Okay, so I want to go back really quick. So I'm going to be talking about glaucoma's alter ego, the secondary suspects. So those of you guys that work in glaucoma or some of the other subspecialties, sometimes glaucoma can seem kind of like mundane. You know, you check the pressure, you send them for OCT, you move on. But glaucoma actually can be pretty interesting, and there's some secondary suspects that are that kind of pop up. And so hopefully you guys learned something from this, and it's a little interactive. But anyway, here we go. So just a brief introduction to glaucoma. It's really like an optic neuropathy in the sense of it's just damage to the optic nerve due to pressure. And so I tell patients when I'm talking to patients and describing glaucoma, I tell them that the optic nerve is basically like your cord that plugs into your HDMI cord that connects the monitor, which is the eye, to the brain, like the CPU. And if like your optic nerve doesn't function, your computer can't work, right? Like I remember when I was a kid, my mom used to take that cord, and so you could turn the computer on, but you couldn't see anything. So the optic nerve really is important. And so it's also important because it's one of the leading causes of irreversible blindness. So, you know, we get patients all the time, they have this really constricted field and they're like, Doc, what can we do? And unfortunately, we can't do anything. Like the key is early detection and then intervention. And so it's often asymptomatic until advanced stages. So actually glaucoma is how I got into ophthalmology. My entire family has glaucoma. So you guys will probably see me as a patient sometime soon. And so anyway, we'll get into it. So this is what a normal optic nerve head should look like. So this is the blood supply, of course. And then this is what we call like a cup, right? And so everyone's cup is different. If you have like a really big nerve, your nerve cup could be a little larger. If you have a really small nerve, sorry if I point at you guys, I'm sorry, learning this. If you have a small nerve, then your cup is usually a little smaller. And so we just follow this, and you can see here that this cup is huge, right? That blood supply is pushed all the way to the side. And so this is what we call a glaucomatous cupping. This person probably has a pretty constricted field and it's probably had high pressures for a while. So there's a bunch of different types of glaucoma. And this is the one we see most often, primary open angle glaucoma. This is the one that's mostly associated with like family history, Black and Hispanic people, trauma, is usually diagnosed somewhere in like, I would say midlife to late. Angle closure glaucoma is usually seen in the Inuit population, so like Native Americans, and then also can sometimes be seen. We see a lot of angle closure. If you go to Dr. Allison's clinic, she does those LPIs, so that's what we used to treat that with. And then normal tension glaucoma is usually seen often in Asian populations. And so the normal IOP, we say it's 10 to 21, but like our bodies are interesting, right? Everybody is unique. And so even though a pressure can be within the normal range, sometimes it's still too high for somebody. And so we call that normal tension glaucoma. That sometimes is really hard to treat because they're normal. And the reason why we care about pressure so much is because like there's a ton of risk factors, like we already talked about race, trauma, family history, but like we're really bad with managing glaucoma because the only thing we can do is control the pressure. So even these people that might have a pressure of like 11, if they're showing glaucomatous changes like we see here in this slide, you just got to keep getting the pressure down, which is really difficult to do. And then secondary glaucoma, which I'm going to present on this today. That's like our trauma, our uveitis, and our steroids. So it's going to be more of like a case format. And so basically, secondary glaucoma, like I said already, it's caused by an identifiable factor. So these people have inflammation or they've had some type of ischemic event. And unlike primary open angle glaucoma, we know why they have glaucoma. And so for these people, yes, you want to get the pressure down, but you also want to address, is it the medication they're on? Is it like do they need an injection maybe for their CRVO, things like that. So just like with non-secondary, like primary glaucomas, you always classify it in two different ways. Is the angle open or is the angle closed? And so we'll get into that. Again, I described the angle. This is the angle of the eye. This is a normal angle. And then this is like an OCT where you can see that. So anyway, I describe the angle to patients as like the eyeball is like a sink, right? Like we make our own fluid and then we have to drain out that fluid. And there's truly no blood vessels inside of the eye. And so how those tissues inside of the eye, outside of the retina, and then all the way to the front, the sclera and the conjunctiva, how they get their blood supply is through, or not blood supply, their nutrients is through this thing called aqueous humor. And so the eye makes it and then it's supposed to drain out here. If you guys, could you appreciate the difference between this and then that? And so this drainage here, I call it the sink. The sink here is closed. And so if you see someone with a high pressure, but their angle looks like this is like open angle, and then this is closed angle. And so we've already kind of talked about this. You have to get the pressure. You have to do gonioscopy, which this is gonioscopy. It's actually really hard to do. And it's like super uncomfortable for patients. So it's not great learning as a resident, but it's okay. Oh, well, I may or may not have given some people some corneal abrasions from that, but all right, gotta learn somehow. So slit lamps, we do OCT and we have to take a really thorough history, right? Family history, know something about their race. It's also good and important, especially, you know, the technicians that are doing family history, ask them if anybody has gone blind from it, right? So you can understand the severity of glaucoma and when they were diagnosed. And then B scan, and then again, like we said, for secondary glaucoma, you really want to treat the cause and not just the pressure. So medical management, you can do like beta blockers, which is like our timolol, the carbonic anhydrase inhibitors, which is like your dorzolamide. I also just talk about it to patients in caps. So like this is your yellow cap, your orange cap, your steroids, you know, those are our pink and white caps, and then anti-VEGF injections. And again, you want to tailor the treatment for secondary glaucoma to the type and the cause. Surgical management, this is what Dr. Smoliak, Mudaseb, and Allison do. And so they do these trabs and these glaucoma devices and cyclodestruction. I don't know if you guys have ever looked on like YouTube and looked at glaucoma surgery. I mean, I think it's crazy. Like we really don't have great ways to treat it. So like for lack of better reason, I just tell people, we basically poke holes in the eyeball and like, okay, create a new drainage system. And then fluid drains. And then we're like, yeah, the pressure's low. And we go from there. It's extremely barbaric, but you know, give us some time. We'll figure out some other things. All right, so we'll start with our cases. This is case one. This is a 45-year-old person with a history of allergic conjunctivitis treated with topical steroids. They present with blurry vision and then an IOP of 32. And their gonioscopy reveals open angles. Any thoughts about what this could be? It's steroid induced, right? And so this is really important for our cornea techs. When you see these patients coming in and they've had PKs, DMAX, and all these chronic steroids, I know we're always like, don't touch the surface. But like if they're on chronic steroids, we like actually really should be checking their pressures because there are a good subset of patients who will become steroid responders. And so this is just basically what happens is like the trabecular meshwork, like that sink, just gets a little rigid and have decreased aqueous outflow. And then the risk is prolonged steroid use. And so more important to check it weeks after steroid use, months, years. You know, again, if you're in the cornea pot, they're like on these steroids for life. So be checking these patients. And usually it takes about 4 to 6 weeks to develop a steroid response. And then there's some evidence that people who have a steroid response, those people are more likely to go on further and develop primary open angle glaucoma too. So we should really be screening these patients and making sure we know their pressures. And then it's important to ask about all forms of steroid use. So this is seen across all forms. You know, of course, most of our patients are on topical steroids, but if they're using any type of inhaled or oral steroids, I mean, technically that risk is still there. And then the treatment, this says discontinue the steroids. There's a caveat, right? Like if you have like a PK, we're not going to discontinue your steroids. And so, but if you're on steroids for like sometimes People can have like robust inflammatory reactions. So maybe they do have allergic conjunctivitis and like we give them a steroid to like calm them down really quickly. And then we give them a pat a day to like take it over, or they take an oral antihistamine. That person definitely needs to come off of steroids. Because like the discomfort from allergic conjunctivitis versus the risk of actual like steroid use in glaucoma, like it's like a no-brainer. So sometimes, we do have to convince the patient, like this is really dangerous and we really need to get you off of it. And then you always want to initiate IOP lowering drops. And so again, that's back going to like our timolol or dorzolamide, all those beautiful, colorful caps. So this is case 2. Does anybody know what this like exam finding is? That is the red reflex. But you see this?
Pigmentary dispersion.
I heard pigmentary. No, Manasi, you cannot answer.
It's not pigmentary dispersion. It's flubbing off.
Yeah, iris is sloughing off.
Clog it up.
Oh, come on. I love this. Yes, yes, yes. Come on. As you can tell. Okay, so this is what, if you guys have ever scribing, this is when they're like TIDs and you like write it down. So these are called transillumination defects. And so this is like she said, like this is parts of the iris kind of chafing off. So in this case, we have a 30-year-old male. He's myopic. He complains of halos around lights after exercise. The IOP is 28. What's normal again? You guys remember? 10 to 21, right? So like crazy enough, 28 isn't like super scary, but it is high. Gonioscopy reveals a heavy trabecular pigmentation. So it's not closed, right? But it's like really, really dark. And so this is called basically pigmentary glaucoma, but this is really like pigmentary dispersion. Yes, it's pigmentary dispersion. It's seen often in younger people, a lot of times males. And so our treatment, you can do laser. This is again a double-edged sword because sometimes laser, like the goal of doing lasers like Dr. Allison and Smoliak do is you want to create inflammation, and then those macrophages, like the cleanup cells, like the catfish of the body, they go and like eat it all up. And so like they go and clean up all the inflammation, and technically you should have more like fluid draining out. But like sometimes when people have heavily pigmented angles, it can just actually cause so much inflammation that the angles can get a little bit more constricted and closed. So anyway, and then pressure control with drops, right? So this is another case. Anybody know what this is? Oh my gosh, I don't even need to be up here. Like, yes, pseudoexfoliation. Outside of glaucoma, anybody else know another type of, like another reason why we really want to know if a person has this? Like another type of workup instead of a glaucoma workup. Anybody know why?
Doesn't look good.
Doesn't look good. Yeah, it also doesn't look good. We're perfectionists as ophthalmologists. Yeah, so it's really important for cataract workup because for these patients, their zonules can be weak. And so that's basically like the suspensory ligaments that keep the lens in place. And so these patients, they're at risk for some complications, some really serious complications during cataract surgery. So important to know what this is. So this is a 68-year-old male. So you can see this is Scandinavian, or 60-year-old Scandinavian female, sorry. They're found to have IOP of 36 during a cataract consult. Slit lamp shows flaky material on the lens capsule, and then gonioscopy also reveals a Samposi line. Again, a pigmented, very pigmented area. And this is called pseudo-X, right? Pseudoexfoliation glaucoma. So this and pigmentary dispersion are the two causes of like pigmentary glaucoma. So pigment dispersion, just to review, the iris is kind of rubbing against the zonules, and that's why you get those like radial TIDs. And then pseudoexfoliation, these like deposits from like that same material that's kind of like whirling around the lens. It can kind of go and basically clog up the trabecular meshwork. Again, both open, right? It's not like the angle is closed. The sink is still running, but it's just a bunch of gunk, And then this is more common, pigment dispersion in younger people. Pseudo-X, we usually diagnose it in older people, and then often associated with certain ethnicities. This is case 4. What's this? I know my like imaging techs, you guys have seen pupils like this, and we're like, get not an OCT, get an Optos, please.
So is the iris, yes, it's Nikia.
Synechiae, right? Like this is like Synechiae. And people who have Synechiae and have an iris that looks like this, what conditions are you guys usually worried about? Iritis. Oh, I actually cheated too because it's right there.
Arthritis, juvenile rheumatoid arthritis.
Yeah, so JIA, like especially if it's a kid, if you see a kid with this, definitely thinking JIA. Adults can get this. You can get this from, well, usually trauma doesn't give you this much robust of a response, but there's a bunch of different, you guys, is a whole different talk, done a bunch of different etiologies. But this patient looks like they're a 35-year-old male with recurrent anterior uveitis, and they present with an IOP of 42. And the exam shows posterior synechiae and then anterior chamber cells. Anybody know what this could be? Yeah, uveitic. So uveitic glaucoma. So those same cells that are like floating around and causing all this inflammation here, they again can like clog the trabecular meshwork, right? Sync is not functioning well, the pressure backs up. And so we call this uveitic glaucoma, not to be confused with like the steroid-induced glaucoma, right? Mechanisms are a little different. This patient is still gonna get steroids. So people like uveitis, like Dr. Shafir and Dr. Who, God bless them, they're like fighting a like never-ending battle. Like this patient needs steroids, but we know the steroids is going to bring up the pressure, and the pressure is already elevated. So then they're going to have to see Dr. Allison because they have glaucoma now. And these are the patients that are like seeing everybody at FLOM, like 9 a.m. with Who, 10:30 with Allison, 1 p.m. with cornea. Yeah. Because they're going to get cornea. Everybody. So I kind of joke with people that once you see one ophthalmologist, you see all. And so uveitic glaucoma, like we talked about, inflammatory cells like clog the trabecular meshwork, and the chronic inflammation can lead to scarring, and then sometimes it can get like angle closure. And so what you want to do is control the inflammation again, like double-edged sword, right? Give them steroids. But you also need to control the IOP with like aqueous suppressants. And so again, these are patients that like automatically are probably getting on everything we got. These are people that are getting like cosobbed, and then like you come back in a few weeks, they're probably being put on like bromonidine and then everything. And this is case 5. Oh, I'm like, why is all my stuff coming up? Okay, ignore this. Do you guys see this right here? So this is rubeosis. All right. And so if you saw the previous like slides, you don't really see their blood vessels there, but like they're very faint, right? Versus these like are very angry, juicy blood vessels. Juicy. Okay. So this is a 62-year-old diabetic with a recent CRVO. They complain of severe pain and decreased vision. Slit lamp shows rubeosis, and their IOP is 48. What's this diagnosis? Yes, this is NVG. This is like a resident's nightmare, okay? Because getting a patient to see glaucoma and retina is like very difficult. So the cases, so neovascular glaucoma, CRVO, PDR, ocular ischemic syndrome, basically like anything that starves the eye for oxygen, the eye then makes these like blood vessels. The eye thinks it's helping itself out. So like it releases VEGF, right? And it creates these new blood vessels. And then those blood vessels kind of block. Can you see this right here? Like that's like neovascularization of the angle. So those blood vessels like start growing everywhere. And so these are like CRVOs, you cut off the blood supply, the eye starve for oxygen, they make these blood vessels. Diabetic retinopathy, like those blood vessels are terrible. The hyperglycemia starves the eye for oxygen, you start making new blood vessels. And ocular ischemic syndrome, same. And so for these patients, they need anti-VEGF injections, but like this is why it's a resident's nightmare, right? They need this, but their IOP is too high, so Dr. Katan doesn't want to do it. So then you run and you beg Dr. Smoliak to take the patient, but then they want retina there too because it's really a retina problem. So it's really difficult to manage because you need retina and glaucoma to really do good surgical intervention. And so these patients sometimes get a vitrectomy and then also need a trav. And so gonioscopy, like we don't do this as much as we should on these patients, But really and truly, CRVOs and proliferative or PDR patients, we should be doing gonioscopy every now and then on them. But in theory, like if we can control the with anti-VEGF, if they're coming to like their retina appointments and they're getting their anti-VEGF injections or they get their laser like they should, this shouldn't happen. But you know how it is. Like, who wants to get an injection in their eyeball? Like, I wouldn't. You would have to strap me to a chair. So I could understand why patients don't always show up for these appointments. They're not great appointments. So this is case 6. Anybody figure out what's like irregular about this picture? Yeah, the cornea, it looks a little hazy. I think that's like actually just the picture. It's me copying and pasting, not like the patient.
Push that blood in the medial corner.
Wait, well, that's.
What's this big chunky thing right here? There's edema, but you see that big cataract? Like that's a huge cataract. Like compared to like this picture, oh, that one's a big cataract too. But this is like a really pretty big cataract, okay? So this patient comes in, they're 80 years old, they have sudden like eye pain, headache, decreased vision, the eye is firm. That's actually like sometimes when I just, when I wanna check my own eye pressure, I just like press on my eyeballs. But anyway, you can like touch a person's eyeballs and kind of get a tactile information about how tense the eyeball is, right? So this person has a shallow anterior chamber and they have a mature cataract. IOP is 54. Anybody know what this is? Angle closure. Angle closure from what? That big chunky cataract. Like it's like pushing up on the iris. And it's closing the angle. So this is why like sometimes, I mean, again, maybe because I do this for a living, you probably couldn't convince me. Like I would have to be under general anesthesia to get my cataracts out. But we really don't like when patients like keep a really big cataract in because they're like complications to everything. So I tell patients when they're coming for their cataract evals, and you guys can tell them too, like the beauty of being like in ophthalmology is like we don't really rush in to do surgery, right? People's vision is so precious and so important that like there needs to be like the benefits have to outweigh the risk. At this point, the benefits definitely outweigh the risk. Like it's time to get your cataract out. So we call this like phacomorphic glaucoma. Then there's this. Okay, what's different here? You could be worried about the angle. Agreed. I probably would check that. Looks like another cataract, right? And this cataract is like brown. Like it's like so it's almost like what we would call like almost like a brunescent cataract, right? Like it's really like orange, brownish. You can tell that that Joker's been there for a while. Like their eye doctor has been like, hey, like we should remove this cataract. Dr. Lee, I don't know if you guys work with her, she always tells the patient, like, you guys aren't doing me any favors. Like this cataract really needs to come out. And so because as it gets really big, like it complicates the surgery. There's more risk involved removing a really, really big cataract. So we like to get it where it's like big, but like not this big. So this is a 75-year-old with a white hypermature cataract. They have a red painful eye. Their pressure is 45. And then on the slit lamp, you can see like this milky aqueous and some flare. Anybody know what this is? It's not endop. It's not endop. This is what we call like phacolytic glaucoma. So basically, my husband's not in medicine, so I describe things around food with him because he tends to understand that a little better. So I tell him that like when we go in and do cataract surgery, the cataract is like in a bag of chips. And like, you know how you like to open up the bag of chips just right? So like you can just like shake it out versus like if you open it, it just goes everywhere. Okay, so that bag is what we call like the capsule. And so in this patient, their cataract has gotten so big that that cataract is now leaking out of that capsule and the body is responding to it. Because you're not supposed to really, like those lens proteins are protected, right? Like that's why your chips aren't stale when you get them. Like the bag is all around it. And so again, it works for my husband. So these patients, their mature cataract has been there for so long that these like proteins are leaking out, the body's responding, and it's clogging the intrabecular meshwork. So in this patient, The angle is not like it's closed. It's not like the phacomorphic, it's a little different. It's just like a lot of inflammation, again, almost like our uveitic glaucoma. So this kind of just sums it up. Phacomorphic, just think about it like the lens pushes the iris forward. And then phacolytic leaky proteins kind of form from a hypermature cataract. Either way, like IOP control, yeah, sure. But like this patient needs to go to cataract surgery like immediately. This is the one time like cataract surgery, it's not really like elective. Like we really need to get that cataract out to save their vision. And so this is our last case. This is a 28-year-old on topiramate started on topiramate for migraines, presents with bilateral blurry vision, shallow ACs, and IOP in the 40s. Any thoughts? She's not on steroids.
That's a migraine medication.
That is a migraine medication. So this is drug induced. So topiramate can actually kind of cause the angle it can close the angle. And so there are some drug-induced glaucomas. So that's why it's really important. Again, like you guys are like the first people to see the patient. It's great to do like that med rec. I will admit I'm not the best with the med rec. You got to do a good med rec because when you see a patient like this, it's really important to know that they're on topiramate, right? Like that's the inciting drug. And so you can try to get their pressure down, but you should probably stop that as well. So drug-induced glaucomas, like I said, you want to discontinue the drug. You want to put them on aqueous suppressants. You want to look for like a really good systemic drug history in atypical cases, and then go from there. So takeaways is like secondary is really interesting. They usually have identifiable cause. You want to gonio the patients. You want to treat the cause, also treat the IOP, and then you want to follow up with them. It's very key. Also want to end with, you guys play a really big role at FLOM. And as a resident, I want to thank you. Tex taught me how to refract. Tex taught me how to do applanation. And so the residents, we really appreciate how involved you guys are in our education. Let me know if you have any questions.
Hi, everyone. It's good to see you all. Some familiar faces, some less familiar faces, but like Jen said, my name is Manasi. I'm one of the PGY3 residents. I'm liking everyone's personal style. I always see you guys in teal and you look good in that, but it's nice to see some different stuff. So the talk I chose to give is eye trauma, the basics. And the reason I chose this topic is because that has been what defined the last year of my life, probably. Also, for the technicians, more and more of you are sort of floating into our UEC space. So I think it'd be great for you guys to get an idea of what it is that you might expect to be seeing there that's different from the regular comprehensive clinics or any of the subspecialty clinics. The other piece of it is that all of those patients eventually follow up with a comprehensive ophthalmologist or they eventually get cataract surgery. So I do hope this will give you some more perspective on what they've been through before they come to you. Yeah, so let's just go ahead and get started. Most of the photos were taken on my iPhone 11. So just, all right, so when you approach these patients, they're usually seen in the emergency department or in that one kind of like shady area of the clinic where the residents work. So take a deep breath. This will probably take longer than 15 minutes. And then depending on the severity of the injury or the context, you know, why this happened to them, they might have a very valid emotional response. So I always kind of mentally reset for a moment because this is a very extremely memorable day for the patient. Even if it's another patient for you, they will tell the story of that eye injury for the rest of their life. So, you know, you got to be nice. Who does this happen to? So over 50% of the time, it's actually in kids, which makes sense. It is the leading cause of monocular blindness in children. So my hope is that this talk will not only make you better at your job, but also just better at being around kids. Definitely male dominant for a variety of reasons. And then these are the things that I'm scared of now: BB guns, paintballs, pellets, fireworks, and anything with a spring. So a part of the technician's role and, you know, the part of my role as a resident is getting a great history so that you have the whole story down, whether it's to plan surgery later or because there's going to be a legal battle later. Just we need to know mechanism. Did it happen at work? Have they had eye surgery before? Because that might make them more vulnerable to more extensive damage from a minor injury. Did they lose vision at the time that it happened? Did they lose vision 3 days later and then come to the doctor 5 days later? So when did the vision loss happen is a huge part of the history. And for some of these conditions, anticoagulants are really important, and we'll get to that later. So I'm just going to go into a few different examples of very common kinds of eye trauma. The first one here is chemical burn. So what do you need to know? What was the chemical? Be a great place to start. So there's acids and bases, alkalis and acids. So alkali examples here, I've listed lye, cement, plasters, but really common one is airbag. So if someone was in a car accident and the airbag deployed and now their eyes hurt, pH paper might be actually really helpful in assessing this patient. So you could tell if they have an alkali injury to their cornea. Acids, obviously the pool cleaning stuff, vinegar, detergents. Mace, extremely common acid that people get in their eyes, whether they deserved it or not. So these are just things to be aware of. And then when taking a history, what I like to do is obviously ask just the general questions, but also something that can be very helpful is the MSDS or the material safety data sheet. This gives you all the information you need to know about the chemical. If you just Google MACE MSDS, you'll get a full sheet, and that can be really helpful because then you can understand what are the common eye conditions that result from that chemical. So I learn all the time because people get hurt in the most bizarre ways. So just taking the time to search something is how you keep learning. What do we do? So we irrigate immediately. This is even before we check the vision. So often these patients will go to the emergency room first. So this doesn't happen in the office all that often. But a lot of times, because we're connected to a hospital at Strong, someone will get something in their eye at work, and then they just walk over to the eye clinic. Before we check their vision on the chart, if they haven't been to the eye wash station, that is the first thing that we do because that is what evidence has shown has the best visual outcomes in the long term. So we don't check their vision, are you 20/20? We just irrigate them, unless you think there's an open globe. Don't do it then. As far as the treatment, just if there's an epithelial defect, we treat it the same way you treat any corneal abrasion with topical antibiotics, sometimes preservative-free artificial tears, plus or minus steroids. These severe burns, I think they were probably more common when there were more folks who worked at like Kodak and Xerox, like in the factory setting. We see less of them now. You'll probably see these patients like years after their initial chemical injury, but they might be on long-term medications, oral tetracyclines, vitamin C to help reduce the inflammation. And then you'll see that even years after their injury, they might still have a lot of difficulty. And they definitely remember the day that it happened. So, and how nice that doctor was and how nice that technician was. This is a very common injury. The reason that I put this picture there is because they look exactly the same. The first time I saw this, it was actually a pediatrics patient, and they were an infant and sleepless parent, you know, was just administering their drops, and wouldn't you know, they put super glue in the eye instead of their Maxitrol. It's actually very, very common. Fortunately, the visual outcomes are good. So if this happens in clinic, don't, you know, you can keep the patient calm. Like if it happens in your life, you can keep your friend calm. This also happens a lot with eyelash glue. So, okay, yeah. This is how we manage it. You just trim the lashes. You remove the adherent glue from the cornea. Jeweler's forceps are the instrument that I like to use for this. Irrigate with some warm, normal saline, and then just treat it like a normal abrasion. If there's super glue in the eyelashes, that's fine. They can just stay there until it sloughs off. Eventually, the skin will regenerate and it'll come off by itself. You can use some warm compresses. The thing we don't want is for it to stay on the cornea and then slowly, painfully come off over the course of days. And so that's what we do in the office. It looks very bad, but it's actually not that bad. So corneal metallic foreign body, I'm sure you guys see this a lot, especially if you've come, you know, and work with the residents. This is one of the most common reasons that people send someone from an urgent care or an emergency department. Many things that we need to know. Did it happen at work is a very important one that we need to know because it totally determines the course for that patient's next attending that they see. It determines how much documentation we end up having to do because if it's a workers' comp issue, it needs to be very thoroughly documented. So what was the mechanism? What was the speed? And the reason that these things matter is because let's say that they were just working and then they felt something go in their eye. That's a little bit different than I was shot by a nail gun in the eye. So there is a possibility of an intraocular foreign body always. Knowing the speed at which the projectile was going can really help us know whether we should be worried about that, although all these patients should get a full eye exam regardless. A hack, try the Prepare-Cane drops before you try checking the vision. So a lot of these patients, I think I've seen people float to our clinic and they're like, the patient can't see anything, but they can actually see quite well often if you just put the Prepare-Cane drops in their eye. For removal, we use an ophthalmic burr, golf club spud, or a needle in a pinch. just treat it as a corneal abrasion. They follow up in a week. So I'm sure those of you who have worked with some of our competendings, you see all these follow-ups, and there's like a note from the resident at 2 a.m. on a Saturday, and it's like 5 words long, but this is what was happening. It could always be this. I took this on my iPhone. So one thing to be aware of, there might be 100 normal corneal metallic foreign bodies. Sometimes it does actually go all the way through the cornea if it's moving fast enough. So this guy, same story as literally everyone else I had seen. He might have been, I don't know, the 50th or 60th or 100th, but for him, the metallic foreign body was larger and it went all the way through the cornea. And he had to be added onto the OR as an open globe. So this is why it's one of those things, when someone calls you over the phone and says, do they need to be seen today? You don't know the answer to that until you see the patient. So I like this photo because you can see that the part that's on the outside that's exposed to oxygen is rusted, and the part that's on the inside of the eye is not rusted because it has not been exposed to oxygen. This patient actually ended up okay. He's 20/30 now. Yeah. So corneal abrasion, you guys all know how to do this. Yeah, these are easy. But it could be worse. So this is also on my iPhone. This was an 8-year-old kid who, those, when you have the blinds, you have that stick that you turn for the blinds. So I guess it had come off, and that was like what the kids were using to play like joust or something. So his sister got him in the eye, and it was treated as a corneal abrasion for like a week plus by like his pediatrician, which I think super valid, understandable. But then when things didn't get better, the vision got worse. It was actually an open globe. So you can see the laceration that's all the way through the cornea and then all that edema around it. This kid also ended up doing okay. It's just one of those things where recognizing it early, it's good to know the difference. So hyphema, this one I took, it's a post-surgical hyphema. So sometimes this can happen after a MIGS procedure. This patient had MIGS and they were on warfarin anticoagulation. The most common cause though is trauma. So basically any kind of blunt trauma to the eye. Baseball is one that we see a lot. The Orbeez guns, that is also very common. Golf, any kind of projectile, fist. All of these things can cause a hyphema. What happens is those small blood vessels in the iris, they undergo that shear force and then they break and it results in blood collection in the anterior chamber. We used to hospitalize people for these. The hospital's full now, so we don't do that. But this is what I tell the patients is we used to put people in the hospital and keep them inclined like this so that the blood would settle out. An analogy that I like to use is that it's just like a snow globe, the eye. So the blood in the anterior chamber needs to settle to the bottom, just like the snow settles to the bottom of the snow globe, and then you'll be able to see. But if you jiggle the snow globe at all, it's all gonna go everywhere and delay. So these we treat, steroid drops and cycloplegia. We follow them very closely because at the 5-day mark, they can actually rebleed. So they're doing better and then all of a sudden they hurt. That could be a sign of a rebleed. And then sometimes this will happen for no good reason, and the patient actually has a medical condition that predisposes them to bleeding. So one of the more common ones that we check for is sickle cell, especially in the pediatric population. Just something to be aware of if there wasn't a reason for this to have happened, like a tennis ball or something like that. These are eyelid lacerations. So these are also all from my archives. Which one of these do you guys think had to go to the operating room? Oh, sorry, which one of these did not have to go to the operating room?
Left, far left.
Okay, Kayla knows the answer. So the answer is this one was fixed at the bedside and the other two had to go to the operating room. And the reason for that is that there are two kinds of eyelid laceration that are more concerning. So again, if you're like with us in the clinic or you're one of the folks who's lucky enough to get to work with us on a Saturday, this is what we're dealing with because that's people like to act up at night and weekends. So, and also dogs like to act up at night and on the weekends. But basically what you don't want is a laceration that involves the lacrimal system. So if you this little toddler here, that small laceration actually was lacrimal involving. So they had to have that whole lacrimal system reconstructed and they actually ended up with a Jones tube. But it looks like a small laceration, but it's the location, just like real estate. Then this one, obviously the margin is involved. So once the margin is involved, the reconstruction becomes more complex. So it's multi-layered because you have to approximate the tarsus, get the meibomian glands together, everything. This one, it looks awful. He dropped a chainsaw on his face, but But he was very lucky because his lacrimal system is spared, and it actually spared the margin, and it spared his eye. And I didn't. He gave me permission to show this photo to anybody because he's really proud of it. But his after photo, I would show you, but he just looks like a normal guy. So it's just one of those things that it definitely depends on where it is. So these are kind of pertinent positives and negatives. Okay.
First one, the dog bite?
Yeah, the first one was a dog bite. That kid. Yeah. So, yeah, this patient was. We don't really know what happened. He was just found down, covered in paint, with a broken picture frame over his head. So, yeah. So a lot of that stuff is paint. Yeah. So. I know. It's like all very exciting and glamorous. Like, so eyelid laceration considerations, like I said, the location. This is what the most important thing. This is how we tell if, these photos are all actually from my personal text conversation with Dr. Gonzalez. If you're like contacting people to talk about it, or if you're handling it yourself, it kind of depends on the location. What's also important to know is it a bite? Because the mouth is disgusting. They might require intense antibiotics, even IV antibiotics, if it's a human bite. Foreign body, do they need imaging? Could there be a piece of something still hiding in there that we can't immediately see? Then you might send them for a CT scan, or if there's wood, then it wouldn't be picked up on a CT scan. So these are all things to sort of ask the patient. Do you think there's something in there? Did it happen from a tooth? Because sometimes you'd be surprised, they don't volunteer that information. Tetanus shot is very important. So when was your last tetanus shot is a question that all these patients should be asked. Remember, the eye could be injured too, obviously. These patients need a full eye exam before we focus on the lids. So all of these patients, probably they need their pressure checked, they need their vision checked, all of those things, even if it just looks like it's on the eyelid, because there could be an occult globe trauma as well. This is one of the more common traumas that we see. I'm sure that a lot of you who work with our comp doctors or in well eye care have seen like the 1-month follow-up visit for these patients. Or if you work kind of with us with the residents, we see a lot of these patients in our clinic. This is an orbital blowout fracture. So the image you're looking at here is a CT scan. This is from Google, not from my iPhone. But you can see that on this side, there is a circle that is the orbital rim. Okay, so the scan is like this. It's a slice this way through the face. And on this side, there is a large defect, and there's a hinge here. That's the broken bone. So it should be just flat like a floor, but it's broken. This is one of the more common facial traumas. This happens like probably once a night, if not more, maybe more. It's Memorial Day weekend. But symptoms, pain, numbness, tingling, double vision, a lot of swelling. Their vision might be down because they're swelling, and their vision might be down because there's globe trauma. So that's one of the reasons these patients need to be seen quickly. Diagnostic studies, we usually go straight to the emergency room for a CT, or if they seem stable, they can get outpatient CT as well. The things that we worry about are entrapment that would require urgent surgical repair. Thankfully, it's relatively uncommon. It's very, very rare. I actually haven't seen one. Have you? Okay, Kayla's seen one. Yeah. Yeah, I think there was one last night. So it's the second one. So this is one of the more feared complications. This one's a patient of mine. This is from my iPhone, but it's obviously a photo of a computer screen. So this is when there's a hemorrhage behind the eye. This results in a hematoma. And what happens is that collection of fluid can compress the optic nerve. And then if the optic nerve is compressed, then you get irreversible loss of vision. There's no cure for it. So the treatment in these conditions is you need to kind of emergently do a canthotomy cantholysis, which is where you cut the eyelid here, move it away from the globe, and then you cut the inferior canthal tendon as well. And it's pretty amazing because these patients will go from seeing nothing to seeing everything because the pressure's off their eye, and it's pretty instantaneous like that. This is a clinical diagnosis, so I don't know like in what situation a person like this will come to clinic, but it's happened. You'd be surprised. So their pressure is like 60, their NLP, they have an APD. Just don't waste time with the history. Just be like, hey, there's something really serious going down in this room. And then they might be in the minor OR getting a surgical procedure within minutes, even if that's the case. So globe rupture, this is one of the more kind of like emergent traumas as well. This isn't a photo that I took, but it's a good one. It's like too good to be taken by me. As you can see, the iris, there's a defect there near the limbus. Probably this patient had a puncture wound of some sort. And then the iris is prolapsing out of the eye and plugging it. So often, especially in kids, they'll be playing with a toy. This will happen. Their eye plugs and the kid doesn't have pain because the eye is plugged up. And it can go, weeks without being noticed. We've seen some where, they just noticed the eye looked weird. The kid wasn't verbal, like it happened. So I guess, I don't know, be careful. These kids, man. I don't really know how to avoid that one. The parents felt really bad, but it happens, like, unfortunately. So if the iris is plugging like that, these patients might actually be pretty well appearing and the eye just looks red to the naked eye. So just something to be aware of. This, I think, is a relatively obvious one. This is like what people like see on their flashcards, on their board exams, things like that. But I've actually, more globes I've seen look like this. So this is a patient of mine. Yeah, so with a blunt trauma, what can happen is there can be what we call an occult globe. So there is a scleral laceration, but it's so far back in the weaker part of the eye that it's not visible when you look at them. I examined this patient. I didn't see a laceration. I just knew that the pressure was 4. And there's obviously all the subconjunctival hemorrhage, so they're bleeding from somewhere. So one of the pathognomonic signs of what we call an occult globe, like this one, is 360 degrees of subconjunctival hemorrhage. That's kind of the buzzword. You guys might have heard that one. And that can happen even from a non-penetrating trauma. So this patient was actually the 1-year anniversary, Memorial Day last year, was like walking down the street and then just like a rock flew up from someone who was mowing the lawn. And so you would not think that that would cause an open globe, but a blunt trauma can absolutely cause an open globe. So just kind of be aware of that in the back of your mind too. This is a picture of the Seidel sign. I borrowed this from Iowa. So when people say Seidel positive, Seidel negative, hopefully Seidel negative, this is what they mean when it's positive. You put the fluorescein strip right on the area where you suspect there's a defect. And as you guys may know, the fluorescein strip should form a beautiful film of yellow all over the whole eye. But you can see this kind of leaking waterfall. That's actually aqueous. It's coming from the inside of the eye, and it's causing the fluorescein to look more like a river there. So this is what, if you see in notes that it says Seidel negative or Seidel positive, that's what that means. Or if someone says, I want to Seidel this guy, what they mean is, get me a fluorescein strip. All right, globe rupture. So management, there could always be an intraocular foreign body. So all these patients get a CT scan to ensure that there's nothing inside the eye, because then we have to call our retina colleagues to get it out usually. Treatment, they get IV antibiotics to prevent the infection from spreading further, even into the brain could happen. Strict bed rest, so they're not allowed to do anything except for sometimes they're allowed to go to the bathroom and stuff, but nothing besides that. They usually get admitted to the hospital and surgery ASAP. So honestly, the questions to ask these patients, like if you see someone like that, like that or like that, probably the next question we're asking them is, when was your last meal? Because we need to figure out when we can fix this. There's a whole other kind of like retina and choroid piece. I condensed it because I had one picture that showed all the traumas. So here's a few common things you might see in notes. So commotio retinae, this is retinal whitening in the periphery. It's really common in blunt trauma. A lot of these patients who have a floor fracture will also have commotio retinae. And what that is kind of a shaking up of the retina. The RPE becomes disrupted, and then you see retinal whitening. I'll show you a picture in a second. Obviously, a retinal detachment. Everyone here knows what a retinal detachment is. I'm not going to elaborate. Choroidal rupture. So you can actually rupture the choroid, and I'll show you a picture in a second here. And these patients, they might follow up in retina clinic in the long term because they develop choroidal neovascularization in the area of the trauma. So this is a patient I saw. And do you guys see the white? Yeah, like it looks like those patients who have a CRAO or something, but that's not the history. This patient was just punched in the eye. So the white is where the RPE has been kind of shaken up. And then you get that white, they call it Berlin's edema. That's like the I don't know, the name that some people use, but usually people will say commotio retinae. That's what they're referring to. Usually it resolves within a week, and it's not a big deal if it doesn't involve the macula or fovea. And then choroidal rupture, do you guys see that white? It looks like a claw, like a cat just came and scratched right next to the fovea. So that's actually a rupture. It's a break that can happen from blunt trauma. So this patient had both, unfortunately. They actually ended up doing okay, though. The eye is surprisingly resilient. All right, so this slide I just have because I thought I would conclude with a few things. This is what I'm scared of after ophthalmology residency. So I'm scared of resistance bands because they can cause blunt trauma. Don't let kids play with Orbeez without swim goggles on because crazy stuff can happen. And then dogs, so cute, but make your kids be nice to them, otherwise they will fight back. This is kind of the last slide. I don't have any text here, but it just bears worth mentioning when it comes to trauma. There's accidents and then there's non-accidents. So I'd say probably about half of the orbital floor fractures I've seen, actually probably more than half, are the result of assault, sometimes intimate partner violence. So if you're seeing red flags in, when you're talking to the patient or there's someone in the room who's behaving unusually, or they're telling you, yeah, like my man beat me up, just tell the doctor that. You can't just, let that go on because, these patients might need a safe place to stay even that night. And sure, their eye is important, but intervening at the right time could save their life or their kid's life. So it's one of those things, you see the thing and we're so focused on one thing. Why did this happen to you is a whole other conversation that's also really important for us to have sometimes. And it's why sometimes it's a 15-minute appointment slot, but these can take longer. That's okay. So thank you, everyone. And I have here the people who made it actually very fun to spend all my weekends and nights at the hospital. A lot of people say that if you go into the medical field, you're giving up your 20s, but I have never felt that way. So thank you to all of you.
Thank you so much for the very kind introduction. Good afternoon to everyone. I don't think my talk is going to be as dramatic as the earlier speakers with all those kind of images. I think retina is probably cleaner than the other subjects, probably. That's what I think. But yes, it's nice to be among you all. And I would like to really thank my earlier techs and nurses with whom I worked. And this was during the farewell that I got a couple of months ago when I left my LV Prasad Eye Institute. And I must say, I learned a lot from my nurses and techs. In fact, when I joined as a fellow or as a junior faculty, the senior nurses would actually give tips of how to manage some of these cases during complex surgery. So we respect them a lot. And in fact, one of these nurses, her name is Jaisama, she she resigned a job at LV Prasad Eye Institute about 14 years ago, and she came to say bye to me during my farewell. It's a really fantastic team that I had. So the office procedures that I'm going to be talking about today are intravitreal injections, lasers, pneumatic, and also cryopexy. Which one of these do you think is the easiest of them all? Correct. So in fact, injections are being given by techs or nurses in many countries in hospitals. Imagine you being privileged and being allowed to give injections in the offices here. It's not difficult. It's not difficult, but there are some aspects of injections which we need to be very careful, should be aware of. And it's not the injection part which is difficult. The complexity is when to inject and what kind of injection. There's so many options of intravitreal injections which we have. Which of those injections should be given to a patient at a particular time that's what is complex, and that requires a lot of training. Any of you can tell which is the most common injection that we give here? Avastin, very good. Anything else that we? Earlier, very nice. Very nice. So there's so many injections and drugs. But just to let you know that all these injections have their advantages and as well as some drawbacks. So Avastin, you might be aware that it's probably inexpensive. That's why that's an injection which most people start off with. But it has the least drying effect on the retina. And these injections are usually given whenever there is swelling of the retina, which we call as macular edema. So without an OCT scan, I think we retina specialists would be flying blind. So that's why you would see a lot of OCT and then an injection. You take out the OCT, we won't know what to do with these retina, what kind of injection to give, whether we should give or not. So that before the injections, this is what the scans that we look at. And someday, if in the United States you are authorized to give injections, you have to learn this as well, right? So you should be able to decide, okay, what injection is to be given. But even if the doctors advise, injection procedures by themselves are not that difficult. We'll come to that later. But this, what you see as black spots within the retina or under the retina, these are always red flag signs, meaning the disease is active. If there is no fluid, there is these black areas, that means the patient is okay, it's dry. You may be able to postpone the injection for that particular visit. But any of these black space, it's a pattern recognition. It's easy to recognize. Black on OCT, go for injection. No black, you can withhold injection. But sometimes we have other pathologies where we may have to consider surgery or vitrectomy. But this pattern of black is when we decide to go for injection. But then we usually start off with Avastin for cost reasons. But if there are no cost consideration, Eylea is much more efficacious drug in terms of drying the fluid. And typically, it's about 20 to 30% difference in terms of the drying effect. And after that, we have Vabysmo. That's more or less equivalent, except that it has a slightly longer lasting effect. Quite often our patients may ask, doctor, how many injections am I going to require or need in 1 year or a couple of years? And that's where these drugs now start to have a difference. Some of them are longer acting, including Ozurdex. Not sure if you routinely use in the practice here, but Ozurdex it's an implant. It can release the drug for many months, and the patients may not need that often an injection. But the crucial parts, components of an injection, just before the injection, you must make sure that there's no external infection or including conjunctivitis or lacrimal drainage system problem, which can lead to infection in the eye. Endophthalmitis is something which is very devastating. That's the last thing you want in a patient post-injection. So we take all precautions that are required to reduce infection. And also any high intraocular pressure, glaucoma, primary or secondary, as long as it's temporary, it's okay to give the injection. But if there is an advanced glaucoma in any patient, sometimes these drugs can cause further damage, especially Ozurdex, which I mentioned. It's an implant, it's a steroid. It can cause steroid-induced glaucoma, and these patients can actually lose vision if given in a patient of glaucoma. Generally, we, in at least the rest of the world, we use gloves for injections and face masks. If not, we should avoid talking when we are giving the injection. The streptococcus in our throat can cause infection when we're giving intravitreal injections. And lid speculum helps a lot because it keeps the eyelashes away from the trajectory of the needle when we are giving the injection. But this, as it's just impossible to emphasize this enough. That always check the correct eye before we give the injection. As I said, giving the injection is very easy, but these are some rules which need to be followed. And I'm not going to talk about that aspect about timeout and other stuff. Topical anesthesia, Paracaine, eye drops, you can use a cotton swab. For some injections, you may need a subconj injection. For some patients who have complained that they had severe pain in the previous injections, you may want to give a subconj, but generally you don't, just paracaine drops are sufficient. Povidone iodine is very important to prevent infection, and an eye speculum to keep the lashes away. So eyelashes, they're never clean. So the trajectory of the needle when you are going to give the injection, that needs to be clear of any eyelash. And again, after the injection is given, it's good to give povidone iodine eye drops. Let me see, yeah. So this is, in India, we generally have a minor operating room where we give injections to our patients. It's not in the office or the clinic room, exam room, but in a minor operating room, we usually even drape the patients. But povidone iodine, which you saw, was very important. And then the speculum to keep the lashes away. It's nicely draped. You don't see any eyelashes. But before and after the injection, povidone iodine is very important. And then Ozurdex, it's a much bigger needle where compared to the other injections of Avastin and the anti-VEGF where you use a 30 gauge needle. This is a 22 gauge applicator. It's generally self-sealing unless it's a vitrectomized eye. If a patient has had a retina surgery and then we are giving this intravitreal Ozurdex injection, then this may leak out. The vitreous cavity fluid may leak out. We need to be careful that these patients may require suturing if there is a hypotony after the Ozurdex injection. But otherwise, in a regular patient, you don't need to suture this implant. Adverse effects, subconj hemorrhage, redness, discomfort, watering for a few hours to a couple of days, seeing a black spot, which is the air bubble which goes in the eye. Patients may feel that. It's always good to explain these before giving these injections because some of these patients get alarmed when they see these bubbles. But endophthalmitis is something which really you want to avoid. Lens trauma. I have seen some general ophthalmologists giving injections. In cataract, typically a cataract surgeon is afraid of going too far back with their phaco probes because you are going to rupture the posterior capsule. You want to stay away from there. So you don't want to go down with the phaco probe. But in intravitreal injection, you don't want to be anterior. You want to angle it posterior so that you don't touch the lens accidentally. So I've seen cataract surgeon who gave an intravitreal injection. I didn't put that video. It wasn't a nice video where it went into the lens, the Ozurdex implant. And then they did the phaco and the implant came into the anterior chamber and they emulsified the Ozurdex implant as well along with the cataract. But training is very important for these injections. So lens trauma or lens touch should be avoided. What do we tell the patients? Some are standard, a little bit of mild pain or discomfort. But if a patient has severe pain, especially associated with blurring of vision, redness, watering or discharge, they should be brought back into the ER immediately just to rule out endophthalmitis. So that's probably the most serious emergency which we need to be looking out for. Otherwise, as I said, I think you all are set for giving intravitreal injections. Right? Any questions on intravitreal injections so far before I move on to lasers? You have any questions on different? Yeah.
So the anesthetic that you use only 0.5% per barricade?
That's what we used to get in India. If there are other concentrations, we can use that as well. Yeah. So lasers, the number of lasers over the last decade has come down significantly. Most common indications being diabetic retinopathy, central retinal vein occlusion, patient who has a neovascular glaucoma, but a lot of them are being managed now with intravitreal injections. This has a little bit of physics. I won't go into too much details of that, but typically solid state laser, ND YAG laser, we would have heard about YAG laser for capsulotomy or iridotomy. They are disruptive. They actually hit the tissue hard that they break up. It's a mechanical disruption of the tissue. Whereas in retina, we generally do a photocoagulation, like a PRP, which is a photocoagulation. So frequency double YAG, while capsulotomy and PI, you want to puncture the tissue. In a photocoagulation, you don't want to rupture the retinal tissue, but you want to heat it up, raise the temperature, generate some heat, and you see the photocoagulation marks because of the heat. And that's with the frequency double YAG laser. And diode lasers are also used for retinal procedures. The typical wavelength for a frequency double YAG is in the green range around 530, 532, and diode laser is around the red range of 800. So diode laser is generally used where if you want to give a deeper burns in the choroid, or if there is some vitreous hemorrhage. So blood, if it's red in color, so you use red color of laser if there is bleeding inside the eye. So red won't absorb red. But if you use green laser in a patient with vitreous hemorrhage, you are going to have less laser going inside the eye because green is absorbed by the red vitreous hemorrhage. So PDT is another form of laser, which is a photochemical reaction. But typically for retina, we use thermal photocoagulative laser, and we don't use mechanical photodisruptive YAG. Very rarely we have used it for hyaloidotomy, for hyaloid hemorrhage. These are the lenses which are used generally for PRP, and we have to adjust for the spot magnification which changes with these lenses. But these give a very wide angle view, and PRP, you may want to give 2,000 to 3,000 spots of laser. So that's a lot of laser which cannot be delivered in one sitting, but we spread it over 2 to 3 sittings minimum. Sometimes they may have to be lasered repeatedly. And some of the indications are diabetic retinopathy, branch vein occlusion or central vein occlusion, neovascular glaucoma, fever, and sickle cell vasculitis. But what does photocoagulation entail? What does it do? It destroys the retina. So when we do laser, PRP laser, let's say for a diabetic retinopathy patient, we are actually destroying the retina so that it does not produce any factors which cause bleeding. So that retina is no longer functional after we do a PRP laser. That's something which future research has to look at. How can we preserve the retinal function? But a lot of these patients after PRP would have a field loss. So that's why patients may complain that after PRP laser, they may complain of blurring of vision, or that their field of vision is narrowed, or their night vision is more blurry. And that's because the laser destroys the retina. And this is how in 2 or 3 sittings we complete these lasers. These yellow spots which you see, it's because of the heat which is generated. The retina is destroyed there. And we do extensive laser right up to the ora so that these blood vessels which cause otherwise bleeding inside the eye, they regress. So this is what we explain to the patients, that when we do these lasers, they may find some blurring of vision after the laser, but the main purpose of laser is to stabilize the vision so that there's no further bleeding. And in fact, the laser takes a while to act. If you do PRP in a patient, the patient may rebleed in a couple of months because the effect of laser takes 2 to 3 months. And sometimes we may have to repeat the laser. Generally, in 6 to 8 weeks, we bring the patient back in, look for regression of the neovascularization. And if we see persistent neovascularization or any other new areas of neovascularization, we add some more PRP in these patients. Yeah. So any questions on lasers that you have? Yeah. So the last procedure I wanted to discuss, which includes cryopexy, is pneumatic retinopexy. This is typically performed in patients with retinal detachment, where otherwise the main procedure which we do in the OR is a vitrectomy or a scleral buckle. But pneumatic retinopexy is an office procedure where you just have to give an injection of gas. And the procedure of injection is very similar to what you would give as in Avastin or Eylea. But we use an expansile gas inside the eye so that it goes and blocks the retinal break, the retinal tear, and the retina can reattach. So that's the beauty about retina, that if you seal the break or close the retinal tear, the retina can reattach itself. So, and I joke to my fellows that in pneumatic retinopexy, the patient is the surgeon actually, the doctor is the assistant, because the pneumatic retinal procedure, the injection hardly takes 5 minutes or a couple of minutes, but the patient has to position for a week or so, which has to be very accurate, unlike a macular hole or a vitrectomy with gas for retinal detachment. In a pneumatic retinopexy, patient has to position very accurately for a week, and that's hard. It's really tough on the patients. And the other thing is, in pneumatic retinopexy, you can either do cryopexy to the retinal tear before we inject the gas, or we can do laser after the injection. The key difference is that laser cannot be performed in a detached retina. It can be performed only in a attached retina, whereas cryopexy can be performed even in a detached retina. So this is cryopexy being performed. You'll see a white reaction right over there. And that's happening because of the freezing. So in cryopexy, the external temperature is about minus 80 degrees Celsius. And the retina freezes and you see this white reaction. Now this can be done even if the retina is detached. But if you want to do laser, then you have to wait for the gas to seal the retinal tear, for the retina to attach, and then you can bring the patient back in for laser after a couple of days. So you might be seeing doctors bringing in patients every other day for doing additional laser after pneumatic retinopexy, or you may be able to do just cryopexy and leave it. The indications for pneumatic, it's quite liberal, but there are some retinal detachment where a pneumatic is unlikely to work, and you can plan straight for an OR procedure like vitrectomy or buccal. So if there are large inferior tears or with significant proliferative vitreoretinopathy, and patients with advanced glaucoma, because in pneumatic retinopexy, we inject a very large amount of gas. It's about 0.5 to 0.6 milliliters of gas that we need to inject, and it's difficult to give it as one injection. Sometimes we give some injection, do an AC tap, paracentesis, and lower the intraocular pressure, then again inject the remaining volume. But the advantage of pneumatic retinopexy is that these gases can expand, and sulfur hexafluoride or SF6 that expands rapidly. So it's quite often used. It's a preferred gas over C3F8 because it can expand rapidly and reattach the retina. But there are significant challenges with pneumatic. It's very tough on patients, but if they are able to maintain position, they can avoid surgery. But they need very frequent follow-ups. Intraocular pressure can go up. You really want to check the patient's light perception after an intravitreal injection because the central retinal artery can really get occluded when the intraocular pressure goes right up to 60 or 70 in these patients, not 25 or 30. So the central retinal artery gets occluded, and you may want to do a paracentesis right away. So we need to be very careful about that. And the other thing is you want to tell these patients about potential risks with any future surgery where a general anesthesia is given. If there is a gas general anesthesia agent which is used like sevoflurane or isoflurane, then these gases which are given as an anesthetic agent for inhalation, they go into the blood, dissolve, and then come into the eye, and they can expand. So if a patient undergoes a 2-hour or 5-hour surgery after pneumatic retinopexy, these patients can have central retinal artery occlusion with permanent loss of vision. That's why it's important to inform these patients, their relatives, and you want to tie a wristband saying that there's gas in the eye so that the ER responders also know about it. Because there have been patients who have lost their eyesight after getting, let's say, a hysterectomy or appendectomy surgery after gas being injected in the eye. And the other risk of pneumatic retinopexy is that there is a higher rate of redetachment or failure in these patients compared to vitrectomy or a scleral buckle. So with that, I would like to acknowledge my colleagues from LV Prasad Eye Institute, Mudit Tyagi and Ritesh Narula, as well as faculty here. Actually, they came to receive me at the airport this week when I landed in from India. So I've been very, very fortunate to have them and you all with whom I'm looking forward to working in the clinic and OR. So thank you again so much for the opportunity.